that hits Bahamians very hard is obesity. So if you're obese, you have a greater risk of developing a more aggressive form of prostate cancer. And if you are diagnosed with prostate cancer, even at an earlier stage, your risk of cure is not going to be as great. So that goes across the board with any cancer. If you're obese, your survival rate is less than if you're fit, healthy, and you led an existence that's admirable in terms of you getting exercise 3 times a week, you watching your diet, you making sure that your body mass index is within normal levels. So another thing that hits us hard in this country, and we all know it, is breast cancer. So unfortunately, there's a very strong correlation between BRCA gene 1 and BRCA gene 2 and prostate cancer. So surprisingly, the breast cancer associated gene has a strong correlation with prostate cancer. So this is very important in men who have a very strong family history of breast cancer, not just prostate cancer. So you can get your BRCA gene and 1 and 2 mutation passed down from your mother or even from your father, and you can be at greater risk of developing prostate cancer in your lifetime. So there are 2 types of breast cancer related genes. There's type 1, and it's actually a mutation, gene mutation, and type 2. If you have the BRCA gene cancer associated gene mutation type 2, your chance of getting prostate cancer by the age of 70 is 8.6 times greater than if you didn't have the gene mutation. For the BRCA gene 1 mutation, the chance of you getting prostate cancer by the time you're 70 is 4 times greater than if you don't have it. So that's significant. So if you have BRCA gene 2 mutation, you're almost certain that you're going to get prostate cancer in your lifetime. And we have to be extremely diligent in picking up prostate cancer so that we can pick it up at an early curable stage. So in these individuals, we might want to even start screening for prostate cancer at the age of 35 instead of the age of 40. So we look at why worldwide Black men have worse survival, worse outcomes for prostate cancer. We have to look at why Black men don't like to go to the doctor. Why? We have to look at social, economic causes and factors as well. They're not going to have the same availability of healthcare because of their poverty in many cases. Many times it's related to their just complete distrust of the medical fraternity as a whole. Even in this country, there are men who will go their whole lifetime not seek any annual surveillance of anything. They'll never have a general physical. So we need to fight this ignorance. We need to fight this fear that men in this country have, not just for prostate cancer, but for doctors in general. We need to pick up hypertension early, diabetes, hypercholesterolemia, colon cancer, all the non-communicable diseases. We need to pick it up early so that we can, if we need to institute medical therapy or behavioral modification or diet modification, we can give you better control and better longevity and better quality of life. So just in general, Black men are hit harder with prostate cancer at a younger age. It's a more aggressive form of the disease. Bahamian men in particular, because they're predominantly of African ancestry, we have a very high risk of developing prostate cancer. As we grow older as a society, the longer we live, the greater risk we're going to have of developing prostate cancer. Obesity is also a high risk factor. We are one of the more obese nations in the world, particularly in the Caribbean, when I talk about per capita basis. And when we look at BRCA gene mutation related to breast cancer, we also have a very high rate. So worldwide, we look at, in Europe, we look at North America, about 1 in 300 Caucasian men are going to have BRCA gene mutation positive. For Black men, it's as high as 1 in 100. So that's a 3-fold increase in incidence. So how do we pick up prostate cancer? So in the last 30 years, we've had the advent of PSA, prostate-specific antigen blood test. It's a simple blood test. It's a simple tick in a blood form where we get our annual physical every year. It's not an extra sample of blood that we need to take. Unfortunately, PSA is not specific for prostate cancer. It's specific to the prostate gland. So there's so many things that are related to the prostate gland, such as an infective process, an inflammatory process, the prostate gland itself becoming very enlarged, benign enlargement. Those can all contribute to an increase in your PSA. So when we look at PSA, it's one of numerous parameters we look at in terms of trying to pick up prostate cancer early. There are further blood tests that we look at. There's urine RNA tests that can pick up prostate cancer, but just for the general public, PSA is the baseline. We'll do more specific blood tests if that PSA is elevated. We start PSA screening at the age of 40. If you have increased risk factors, a strong family history of prostate cancer, for example, if you're BRCA gene mutation 1 or 2 positive, or if you have first-degree relatives, a father or brothers who are being diagnosed with prostate cancer early at the age of 50, we're going to start screening you at the age of 35. There is no normal per se PSA value. It's very individualized, but in broader terms, we look at between 0 and 4 being quote unquote normal, between 4 and 10 being a gray area, and being above 10 being abnormal. But as I mentioned, there's so many things that can cause your PSA to be grossly elevated. For example, if a man has some retention for one reason or the other, he isn't able to pee for 24 hours, 36 hours. His PSA can go from 2 to 36 to 35 to 40. It has nothing to do with the occurrence of prostate cancer. It's because of the inflammation of the prostate gland itself. So you have your bladder full of urine pressing underneath on top of the prostate that lies anatomically underneath it. That's going to cause your PSA to go up. If you have prostatitis, infection of your prostate, your PSA can shoot up to in their 20s, even low 30s. If we treat you with antibiotics, it can go down to 2, 3, 1. So don't be alarmed if your PSA is elevated. We have to, as a urologist, determine why it's elevated. And obviously, one of the reasons it can be elevated is prostate cancer. So when we're looking at PSA, how do we utilize it better? They're more advanced, the new biomarkers coming, there are more trials ongoing for using more specific biomarkers for picking up prostate cancer early. We have the advent of imaging, such as a 3T prostate MRI or a PSA PET CT scan. We look at genomic testing as well, genetic testing. We're trying to pinpoint prostate cancer when we can pick it up very early, to the point where we're picking it up so early, it's clinically insignificant, and we can watch you in the form of active surveillance before we need to cure you. So another way we're looking at improving PSA is we look at PSA density. So that's an amount of PSA that's produced for every gram of prostate. So the normal size of a prostate is 12 to 20 grams. If a man has a huge prostate, let's say 220 grams, versus a man who has a 15-gram prostate, which is normal, we want to be able to compare the PSA of the gentleman with a 15-gram prostate with a gentleman with a prostate that's 220 grams. So for every gram of even normal prostate, it contributes to your PSA being elevated. That's where the PSA density is so important. It tells you for every gram of prostate, how much PSA is being contributed, and we can determine whether you having a huge prostate has caused your PSA to be elevated. We also look at the percentage of free PSA. So if your PSA is between 4 and 10, we can look at the free PSA, and it gives us a statistical probability whether you're likely to have prostate cancer or not. Another misconception is if your PSA is low, you don't have prostate cancer. 15 to 20% of all men who have prostate cancer have a normal PSA between 0 and 4. So if you have a PSA less than 4, it's less likely that you don't have prostate cancer, but it's still a possibility. The higher your PSA, the more likely you're going to have prostate cancer. Between 4 and 10, your chance of having prostate cancer might be as high as 20%. Above 10, as high as 50%. It's also age specific. So the PSA normal for a 40-year-old is a lot lower than a PSA normal for a 65-year-old. So I spoke enough about PSA density. PSA velocity is also a very important tool that we use as a urologist. So we don't want to look at just what your PSA is in isolation. We want to look at what was it last year, what was it the year before, and what is it now? Has there been a great increase from one year to the next? That can clue us in that there may be a chance or a statistical greater probability that you might have prostate cancer. So if you have a PSA value of 0.5 one year, and then the next year it's 1.5, although 1.5 is still said to be in the normal range, that's a great jump from 0.5 to 1.5 in the space of 1 year. So then we're going to be very diligent in trying to determine why you have that jump in PSA. It doesn't necessarily mean prostate cancer. It can may mean something as simple as you're not emptying your bladder completely. It may be something as simple as you may have an infection of your prostate. It might be that your prostate is increased in size and you just have a very normal but large prostate. So we talk about MRI. MRI is extremely important. It's an extremely important modality, 3T MRI in picking up prostate cancer, not only in screening, but in terms of actual surveillance for persons who have low risk, low volume disease, where we're actively surveilling you. So let's say someone has a high PSA. What are we going to do? First of all, we need to rule out any other causes that might be contributing for that the PSA being elevated. Once we've ruled that out and still there's a strong clinical suspicion for prostate cancer, in the past, all we would do is biopsy. You had a PSA of 5, biopsy. PSA of 6, biopsy. PSA of 4.1, biopsy. But what we found is that as many as 60 to 70% of biopsies that we were doing, and biopsy is not in an inert technique, it's quite invasive, were unnecessary, where we were either finding that the biopsies were negative or that we were understaging the disease, or that when we picked up the prostate cancer doing the biopsies, we found that the prostate cancer was clinically insignificant. That's why it's very important to do imaging. So if I have a patient who has a PSA that's gone from 0.5 to 1.5 or from 0.5 to 2, and we've ruled out that they don't have any infection, they don't have any prostatitis, they don't have any element of incomplete bladder emptying, I may opt, obviously this is on a case-by-case basis, I might opt to do imaging in the form of either a 3T MRI or a PSA PET CT scan. That can pick up with a very high sensitivity and specificity, whether you have even very early prostate cancer. And if you have any suspicious lesions, we can use that information either cognitively, knowing where those suspicious lesions are, or we can use software, computer software, where we fuse the images of the ultrasound that we use to do biopsies with the MRI images to do real-time biopsies, so we can do biopsies that are directed to those specific lesions, so we can get an accurate biopsy sample. So in the past, if you did a biopsy without any imaging, it's possible to miss a small focus of cancer. It's also possible to pick up a small focus of low-grade cancer when you have a higher grade of cancer elsewhere in the prostate. So just because you have prostate cancer, it doesn't mean it's uniform. You can have low stage disease in one part of the prostate, and you can have higher stage in another part of the prostate. So for prostate biopsies, we have to have a strong reason for doing it. And the only way we can diagnose prostate cancer is if we have a pathological specimen. We need a tissue diagnosis. So there are a lot of shortcomings of just doing systematic prostate biopsies, which I got into. That's where we need to do image before we decide whether we need to do prostate biopsies or not. So this is just an example here of doing MRI-guided prostate biopsies, using that information of the MRI fused with using computer software in real time while we're doing the biopsies. And this is a little bit beyond the layman's use in terms of interest, but this is one of the machines that we use to fuse the MRI images with the ultrasound. Further images there. Okay, so how do we improve screening? There are many ways of improving screening. Obviously, we want to key into the important demographic. 40 years old and older in this society, where we're at particularly high risk of getting prostate cancer, particularly aggressive form of prostate cancer, we need to start screening. If there are any other risk factors, such as first-degree relatives with prostate cancer at early age, or as I mentioned, BRCA gene 1 or BRCA gene 2 mutations, we're going to start at the age of 35. So what is the treatment for prostate cancer? Men have this great fear, particularly in this country, of we hear prostate cancer, you think death. We can cure your prostate cancer on a Saturday. You can be back to work on a Monday, where everything is done minimally invasively, where there's little to no recovery, little to no pain. And you can, if you pick up the prostate cancer early, you can have the same quality of life before and after the curative procedure. So prostate cancer can be nothing more than a little bump in the road, where you go through a little procedure on a weekend and you're cured. And you can look at prostate cancer in your rearview mirror, go on with your life. So we have to categorize it: low risk, very low risk, intermediate risk, very high risk, and metastatic. Obviously, the purpose of this talk, the purpose of screening, is to try to pick up prostate cancer where it's very low risk, very low volume, early disease, even clinically insignificant disease. So what are the treatment modality options available? The first is active surveillance, where we pick up the prostate cancer, we've confirmed it's very early, we can actively surveil you until the time for cure. If you have intermediate risk or high risk, and it's still organ-confined disease, we can offer you surgery. Surgery is minimally invasive. It can take the form of laparoscopic radical prostatectomy, where we remove the entire prostate, plus or minus removing lymph nodes, where we use keyhole little incisions, long instruments looking up on the magnified high definition screen, or we can use a Da Vinci robotic robot, where the same thing, small little keyhole incisions, minimal to no recovery. Hours after the surgery, you're up and about, walking around. The next day, you're home. We can provide radiation. And the important thing about radiation is that we use image modulated radiation. So we're directing the radiation only to kill the prostate cancer cells. It leaves the surrounding structures untouched. So you don't have any side effects related to your rectum or your bladder, which are adjacent structures next to the actual prostate gland. You can have brachytherapy, where we place either low dose or high dose radioactive seeds. So we do a 3D reconstruction of the prostate itself. We make use of a nuclear physicist, and we strategically, in a minimally invasive procedure, using a small probe when you're asleep, to put the seeds that disperse radiation for a few millimeters, killing only the prostate cancer, leaving the rest of the normal gland intact. And that's an outpatient procedure with no recovery whatsoever. It has an excellent cure rate, equal cure rate to even the Da Vinci robotic prostatectomy with fewer side effects. We can do HIFU, high intensity focused ultrasound, where basically we are using sound waves and heat waves to destroy only the prostate cancer, leave the rest of the gland intact. We can do focal cryotherapy, so we can freeze the prostate cancer, leaving the rest of the gland intact. And many times we have to do more than one modality. So we might need to do brachytherapy with radiation, with something what we call androgen deprivation, where we might need to give you medications or injections for 18 months to 2 years after we've done the curative treatment, to make sure that in those select individuals who are a higher risk for recurrence, we don't have that recurrence of the prostate cancer. So another thing I want to take away is that fear that prostate cancer is painful. It takes a lot of recovery. It's minimally invasive. no matter what treatment modality you choose. Almost all the treatment modalities have the same cure rate. All of them have certain side effects, certain risk factors, but it all is on a case-by-case basis, and you can choose one of them. There's no wrong answer in terms of which modality you want to treat. Obviously, you have to, there are patient factors, there's disease factors as to if you're a candidate for one of the modalities I just mentioned. So what do we want when we talk about prostate cancer? We want the trifecta. We want you to have urinary continence. That means we don't want you to have any urinary issues, no leaking. When you cough, you sneeze, you go to the gym. We want to have your erections the same before and after any treatment modality. And we want to make sure that your prostate cancer is cured and it's not going to come back. So the first thing we want to do as a physician, as a surgeon, is you want to do no harm. So this is an example here. You can look at this X-ray of the pelvis where you can see the placement of brachytherapy seeds. So a brachytherapy seed can fit on the index of your finger, on the tip of your finger, and it's that small. So for metastatic disease, and I'm very sad to say this, and that's the vast majority of persons that we see in this country, particularly in the public system. So I can't remember the last time I found someone through the public system at Princess Margaret Hospital where they're actually at a curable state. The disease is always outside the confines of the prostate. Many times it's already spread to cause obstruction of the kidneys, and unfortunately cause spread to the spine. We need to pick up prostate cancer early in this country, and we're not doing our due diligence by spreading the word, by taking away this ignorance that prostate cancer is a death sentence, and we're letting too many men die needlessly or suffer needlessly from metastatic prostate cancer. So a lot of men have this macho attitude that when I die, it's my time. But prostate cancer is usually a slow, lingering, painful, extremely expensive death that you may last 7 years, 8 years, 10 years, 12 years. When, if we had picked up prostate cancer 5 years earlier, we could have cured you in a weekend and you didn't have to go through any of that, and you could have had another 25, 30 years in this life with sparing your family, your children, your wife, your grandkids from seeing you die slowly of prostate cancer. Another emerging treatment that has great promise, particularly in men of African ancestry, is actually immunotherapy. So there's so many ways we can cure prostate cancer. And as I mentioned at the onset of this talk, if we can pick it up early, the cancer-specific survival at the 10-year mark is as high as 98%, which is extraordinary. So when we talk about how do we treat advanced disease, prostate cancer is not for cure, it's for palliation. What we do is we try to do an androgen blockade. We try to reduce the testosterone to as low as possible. Why is that? Because prostate cancer, once it's present, requires testosterone to proliferate, to grow. It's basically the fuel, the food of prostate cancer. So if we pick up prostate cancer at an advanced disease state, we want to lower the testosterone as low as possible. We can do that medically by giving you injections every 3 months. We can do that surgically by removing the testicles. I know it sounds crass and many men cringe when they hear that. Or we can just provide you medication every day. Unfortunately, when we lower the testosterone, it has many side effects. It can increase your risk of cardiovascular death, particularly in those who are at a high risk of stroke or heart disease before. You can develop pulmonary embolism, deep vein thrombosis, I mentioned stroke, heart attack, just from the androgen deprivation. It reduces your quality of life. You're gonna put on weight easily. You're gonna have hot flashes. You're gonna have easily fatigued. Your erections are gonna be terrible. You're gonna have a decline in your mental acuity or your cognitive ability. You're gonna be prone to depression. So it decreases your quality of life. It makes you old before your time, and it's only a temporizing measure. Prostate cancer is such an ingenious disease that it's actually going to find a way to bypass our androgen blockade, and usually in 2 to 3 years, us trying to starve the men with advanced prostate cancer up to testosterone just stops working. So the disease becomes castrate resistant. So lowering their testosterone really has no benefit when that happens. So I want to try to reach as many people as possible so that we don't have men in this position where all we're going to try to do is give them palliative care, try to give them a few years of good quality of life. Let's just pick up prostate cancer earlier and easily cure. So the side effects, and I'm not exaggerating, go from one extreme to the next, from lowering a man's testosterone. So this is just exactly what I said. You can even develop breasts, there's muscle wasting, you can have increased risk of brittle bones, osteoporosis, fractures. So the last thing you want to do is have to go through androgen deprivation, particularly for Bahamian men who love their erections. So what if we treat you with prostate cancer and it has a recurrence? If we can pick it up early, the risk of recurrence after we've cured you, even if it's 5 years, 10 years, 20 years down the road, is extremely low. But obviously, even if we've cured you, we're going to still surveil you at first every 3 months, every 6 months, and then after the 5-year, 10-year mark, we'll go to every year. If it does recur, we can employ a lot of treatment modalities that can give you an excellent cure rate, even if it does recur. But the take-home message is let's pick it up early, let's treat it early, and the chance of cure is excellent, chance of recurrence is extremely low. So when we talk about any cancer, we have to talk about the emotional, the mental stress that it causes, the anxiety, the depression. What I've said, I hope has some reassurance that prostate cancer is very easy to cure. It can be cured minimally invasively, almost painlessly, in minimally invasive procedures where you have little to no recovery. So this whole anxiety of being diagnosed with prostate cancer stops you from seeing a urologist or going to your family practitioner or general practitioner just for an annual physical because you're scared of what they'll pick up. You're living in ignorance, and all you're doing is causing irreversible damage to all of your organs. If you miss hypertension or uncontrolled diabetes or prostate cancer, you're missing the boat, the opportunity to cure you when it's at a curable stage. So before choosing any treatment modality, you want to look at what are the consequences of therapy. There are side effects with any treatment modality. That's why if we can pick up prostate cancer very early, we can offer people active surveillance where you don't even have to treat anybody because the disease is of no consequence if we just watch it until we need to cure it. The reason for that is even in the best hands, in the top institutions in the world, every treatment modality has some potential side effect, even if it's because of the actual surgery itself or because of the radiation or because of the placing the radioactive seeds. A small percentage of men are always going to have some element of complications, whether it's a urinary leak that might last a few weeks or a few months, or a momentary reduction in the quality of their erection. So why take someone in the prime of their life where they have no urinary complaints, where they have excellent erections, and the prostate cancer that we just happen to pick up is of no clinical significance to a patient? We can watch you very carefully. In many cases, we can go 8, 10, 12 years before we need to cure you. So those are 8, 10, 12 years before you are subject to possible, even a small chance of any side effects of any curative treatment modality. But obviously, active surveillance is not for everyone. Some people, once they hear cancer, they don't have the mental fortitude, the emotional strength to know that we're not curing you right away. So in those select individuals, we'll just cure you. The chances of any side effects are very small, particularly when we pick up the prostate cancer early. But if we do pick it up early and it's clinically insignificant, for those patients with a prolonged discussion with your urologist, we can always opt for active surveillance if you're a candidate for such. So there are many benefits to active surveillance. We're not over-treating patients who have clinically insignificant prostate cancer. We have to weigh the pros and cons, the benefits of treating someone versus watching them. And that's going to be on a case-by-case basis for each individual with prolonged discussion with the urologist. So there's a lot of misconception between the terms active surveillance and watchful waiting, even amongst my physician colleagues. It's actually, they're on opposite ends of the spectrum in terms of where we're picking up the prostate cancer. So active surveillance, as the words will indicate, we're actively surveilling you until we can cure you. Watchful waiting is when we have advanced incurable disease where the disease is beyond the confines of the capsule of the prostate, and we're just watching for symptoms of the advanced disease to treat only the symptoms. So in any patient with prostate cancer, we have to look at age. If someone's unlikely to live 10 years, for most cases, prostate cancer is slow growing, we are not likely to need to treat you. So if we get an 80-year-old and we find that he has early prostate cancer, and most 80-year-olds are going to have some element of prostate cancer. So most places in the world, we stop screening using PSA at the age of 70. In this country, we might push it to 75. If you have any suggestion of symptoms of possible advanced prostate cancer, we'll try to do PSAs when you're in your 80s. But we're not going to screen every 80-year-old because we're going to pick up prostate cancer if we look for it. In many cases, you're going to die of old age before the prostate cancer becomes of any clinical significance. So basically, God has made us that almost every man is going to develop prostate cancer if they live to or blessed with advanced age. There is very strict criteria for active surveillance. This is more for physicians in terms of who is to be included and who is not. Let's talk about the elephant in the room, prostate exams, the dreaded DRE. Men in this country are scared of the homophobic connotations of having a man stick their finger in their rectum. The good news is that worldwide, many governing bodies, even from family physician governing bodies from Australia to New Zealand to the UK to even North America, the use of prostate DRE just in routine screening really has limited role because we're trying to pick up prostate cancer with more specific either genomic testing, blood tests, urine tests, imaging, before we can even clinically palpate any suspicious nodule. So even if you look at what is the benefit of doing the dreaded DRE, it's very subjective. So one urologist might feel something's abnormal, another urologist doesn't. You can have a clinically benign feeling prostate. There's no nodules, there's no craggy areas. It feels completely smooth and still have prostate cancer. You can have a nodule and doesn't necessarily mean you have prostate cancer. So prostate cancer staging, the DRE does have a role, but am I going to do a DRE on a 40-year-old who has no family history of prostate cancer? No, because all it's going to do is cause that same man never to come for prostate screening again. And it's not going to pick up any prostate cancer that's clinically significant when your PSA is in the normal range or there isn't a high jump in your PSA from one year to the next. So this is just a little timetable in terms of if you are for active surveillance, how often we do it. We usually do follow the North American system of doing a repeat biopsy at 1 year, 4 years, and 7 years, or you might follow the UK system where we repeat the MRI of your prostate every year, comparing one MRI imaging with the next. So when to intervene in terms of when your prostate cancer is elevated, we look at the doubling time. PSA velocity is extremely important. PSA is very important. So in summary, I know I'm going over time. Stop worrying about the dreaded DRE. For the most part, we don't use it in annual prostate cancer screening, particularly if you're in your 40s. Most men get prostate cancer at the age of 64 to 66. Bahamian men are at extreme risk of developing prostate cancer. As many as 1 in 6 are going to get it in their lifetime because of we're living longer. First of all, advanced age is a risk factor for prostate cancer. We're primarily of African ancestry. That's a very high risk factor for prostate cancer. As a nation, we're obese. We have too many obese men. That puts us at greater risk of having a more aggressive form of prostate cancer. And we have a high incidence of BRCA gene 1 and 2 mutation that puts us at a greater risk of developing prostate cancer, a more aggressive form of prostate cancer. So let's pick up prostate cancer early. Let's start the screening at the age of 40. Prostate cancer can be treated by so many different treatment modalities. All of them are minimally invasive. All of them require minimal to no recovery. All of them can be done on a Saturday, and you can, without exaggeration, be back to work on a Monday. So prostate cancer is not a death sentence. The prostate cancer specific survival can be as high as 98% at 10 years. Prostate cancer is very easily cured. So let's pick up prostate cancer early as a nation. Men, stop this ignorance in terms of not going for annual surveillance for prostate cancer every year starting at the age of 40. And we can cut down the number of men who are dying unnecessarily of prostate cancer in this nation. Thank you very much.
We're now going to open the floor for questions. So if you have a question, you can either raise your hand or you can go ahead and type it in the chat. Okay.
Dr. Pinto, you use the word cure quite frequently on a Saturday and back to work on a Monday. Can you expand again as to what exactly would be involved in such a procedure on that Saturday?
So as I mentioned, there are many different treatment modalities. There's no right or wrong. It's usually patient choice. Depends on disease factors, the stage, even for certain treatment modalities, your body habitus. There might be some contraindications to certain treatment modalities because of the specific condition of the patient. But for the most part, either you choose surgery, which can be done minimally invasive. You can try radiation, which is also minimally invasive and painless. You can try brachytherapy. So the only one that has a prolonged treatment regime where you might go up to 10 weeks is the external beam radiation. The other ones are one-time treatments, from the surgery to the brachytherapy to the high intensity focused ultrasound to the focal cryotherapy. All of them can be done even within an hour to 2 hours, and you can even go, for the most part, other than the surgery where you're going to stay overnight, go home right away. And you're cured. If you pick up early prostate cancer, whatever those treatment modalities I mentioned, your chance of cure is excellent, even 99%.
Go ahead, Gregory Williams.
Yeah, I apologize for coming in late, and I have a feeling this may have been covered already. But what are some of the symptoms that you can identify that might be related to prostate cancer?
Okay, that's an excellent question. The fact is that there are very little to no symptoms when you pick up early prostate cancer, very little. So what we want to do is pick up when you have no symptoms. So if you're waiting for symptoms, you're going to wait till it's too late, because the vast majority of patients that we pick up with early prostate cancer have absolutely no symptoms. So if you're waiting for issues of urinary frequency, urgency, waking up in the night, statistically speaking, that's related to benign disease. But we're trying to pick up prostate cancer where it's on a blood test, on your urine tests, and further confirm with imaging, then biopsy, where you have no symptoms whatsoever.
Okay, there's a question in the chat from Laverne Nixon. She says, how does diet affect the onset of prostate cancer and/or infection?
Okay, also a very good question. So diet does play a role. As I mentioned, obesity also leads you to have a more aggressive form of prostate cancer. So that's why so many Bahamian men are in trouble. So obviously a healthy diet is important for just every general health in general. I mean, if in terms of cutting down the risk for colon cancer, in terms of cutting down the risk of you developing hypertension or diabetes or having that more difficult to control, or you having high cholesterol. So even if you picked up a prostate cancer at an early stage, if you're obese, your prognosis is not as good. If you're obese, you're at risk of having a more aggressive form of prostate cancer. So particularly for Black men, they found that if you have a very high intake of dairy products, you have a higher risk of more aggressive form of prostate cancer. If you have a high intake of processed foods, red meat, you also have a higher risk of developing prostate cancer. So if you're a vegan, your chance of getting prostate cancer at a more aggressive form is less. So they've looked at, I'll talk about one study. They looked at why do Asian men have the lowest risk of prostate cancer of all racial counterparts, amongst all their other racial counterparts. And they've pinpointed it to environment and diet, not just genetics. So they looked at men in Japan, and they found that once they moved to California, within one generation, their risk of prostate cancer is the same as their North American counterparts compared to their cousins, their uncles who've still stayed in Japan. It's because of their diet. So you don't want to have too much saturated food, processed food, not too much red meat, more white meat, more chicken, reduce the salt intake, and your risk of prostate cancer is going to be reduced. We can also do chemo prevention. So there is actually a drug.
Red meat.
Yeah. So
Don't eat much
there
salt.
actually is a drug, a medication that you can give men.
No processed food.
And studies have shown that you can reduce your chance of getting prostate cancer.
Okay, thank you very much. We have another question from Wendy Constantine. What is a Terp procedure? And if you had that procedure, does that mean you have cancer or just an enlarged prostate?
Sorry, can you repeat that?
What is a Terp procedure, the transurethral resection of the prostate?
Okay, so that is a endoscopic, minimally invasive procedure where we're going to excise, remove the obstructive element of prostate tissue in front of the opening of the bladder. So every man is going to get some element of an enlargement of their prostate from the time they're 45, some people even 40 and older. By the time you're 70 years old, probably 60%, even 70% of men are going to find that they have element of urgency, waking up in the night to urinate, called nocturia. The urinary flow is not as strong as it used to be. All that is related to an enlarged prostate, and in many cases, statistically speaking, it's benign, non-cancerous enlargement. So a TERP is a minimally invasive procedure that we do to relieve those obstructive symptoms, where we can give you a strong flow of urine, like an 18-year-old. Again, you can hit the wall, dent the wall. You don't have to wake up so much in the night to empty your bladder. You're emptying your bladder when you do urinate. You don't have that strong urgency. You can hold your urine for longer periods of time. If you have advanced prostate cancer as well, you can still have obstructive urinary symptoms. We can do what we call a channel TERP. So we create a channel within the obstructive tissue to allow you to empty your bladder, stronger flow, less urgency, less frequency. So it's not a curative treatment for prostate cancer. It's a treatment for urinary symptoms of incomplete bladder emptying or urinary urgency or frequency or weak flow.
Okay, thank you. Dwight Benaby, you can go ahead with your question. Dwight Benaby?
Yes. Good night, Doc. I heard you several times refer to obesity. And, you know, in the Bahamas, we always think of obesity as fat people. But let's say for me, I'm a 60-plus young man, and I've been trying to get to what the chart says my optimum weight. I'm 5'9", and the chart say 165 pounds. But I've been trying to get under 180 for God knows how long. I mean, I'm not able to run as much as I used to or jog because I had spinal surgery. But I don't feel fat, but I just feel I just can't get that down to that 165. Please help me out, Doc.
Okay, so any man over the age of 40 where they have issues of the feeling they don't have the same stamina, where they feel that they have put on 20 pounds, 30 pounds, they can't lose that weight, they're watching their diet, they're going to the gym, they're exercising. The first thing we're going to do is check their testosterone level. So from the age of 40, everybody's testosterone level falls every year. So when you think of testosterone as a male hormone, it's important for every system of the body. It's protective for the cardiovascular system. It's important for maintaining a normal bone density, for maintaining your muscle mass, to prevent you from putting on weight unnecessarily. It also has a very strong correlation with obstructive sleep apnea, where your wife is telling you snore all night and you stop breathing for a few seconds and they are terrified that you've stopped breathing. That might be obstructive sleep apnea, which can cause you to have low testosterone. So low testosterone can cause fatigue, unwanted weight gain. So you very likely have low testosterone. If you do have low testosterone and we've ruled out that you have any chance of any prostate cancer, we can supplement your testosterone. And I've seen men who are symptomatic for low testosterone hypogonadism lose 20 pounds and 30 pounds in 6 months with the same diet, the same regime, but we've corrected their testosterone. So for you, sir, I would check your testosterone level. At the same time, we'll check your PSA.
Thank you, Connie. Well, I do that just about every year, the PSA check. But thank you very much for the information on the
Yeah, so it's not standard that you're
I
going to
think
get.
you hit the nail on the head there.
Yeah, it's not standard that you're just going to get your testosterone checked. So insist you get your testosterone levels checked.
Good, thanks very much. So actually, I'm supposed to go get a physical tomorrow, so I'll mention that to my doctor.
Okay,
Thank you, sir.
no problem.
All right, another question from the chat. Good evening. What are the costs associated with each method mentioned, and are they all available in the Bahamas? Thank you.
Yeah, so that's difficult to say because there's so many different scenarios related to that. They're trying to rule out NHI, and one of the first things they're trying to rule out NHI with is for prostate cancer because it's so prevalent in this country, where the goal is, I don't know, because of the setback of Hurricane Dorian and because of this COVID-19 and the government being broke, it's probably set back that rollout several years, but the goal is eventually that we're going to be able to treat every man with prostate cancer for free, government sponsored. We haven't reached that point yet, but screening, of course, is still covered. So there's no excuse for someone not getting annual screening, particularly with PSA for prostate cancer. But through the government system, through Princess Margaret Hospital, radical prostatectomy surgery is readily available. External beam radiation is readily available. High intensity focused ultrasound used to be available in Bahamas. Unfortunately, it's not available right now. I'm trying to roll that out. Focal cryotherapy is something I'm rolling out along with brachytherapy. I was also slowed down by the COVID-19 pandemic, but within a few months, that's also going to be available. So hopefully within a year, all treatment modalities will be available. Cost shouldn't be an issue because you can get it through the government system.
Thank you. And I have a question from Frankie, and if I ask this wrong, you can correct me. But he wants you to speak to diet, tomatoes, warm water with a spoonful of honey and lemon, etc., I guess, and its role in prostate cancer prevention.
So they've looked at everything, every element of diet. So in terms of governing bodies, the American Urology Association, the European Association of Urology, in terms of specific dietary advice, they're not going to say honey or grains or prunes, or what they'll do say, as I mentioned, restrict your dairy intake, red meat intake, processed foods. But you can do what we call chemo prevention. There is a drug. It's under the class of 5-alpha reductase inhibitor. It's either dutasteride or finasteride. If you take one of those drugs for as long as 7 years, it reduces your chance of getting prostate cancer by 25%, which is significant. It also has the benefit of reducing hair loss as well. So that's an added benefit. So If you're particularly high risk of developing prostate cancer because of family history, because of other contributing factors, it might be a good idea to put you on finasteride or dutasteride because it can reduce your chance of getting prostate cancer by as much as 25% if you take that medication up to 7 years. An important thing that you need to be aware of and your physician needs to be aware of is if you take one of those drugs, finasteride or dutasteride, for more than 5 months, it artificially halves your PSA. So that's extremely important for prostate cancer screening. So if you have a PSA of 1 and you've been on dutasteride or finasteride for more than 5 months, your PSA is actually 2. Same thing, if your PSA is 3 and you're on one of those drugs for more than 5 months, it's actually double it, 6. So if you don't double it, not knowing that it's artificially halved by taking those drugs, we're going to miss prostate cancer in the early stages.
Okay, so thank you for that information on those preventative drugs. The next question is, are there any supplements that men should be taking as a preventative measure?
So the only real chemo prevention that is advocated are the drugs I mentioned, and that's the Avodart or the finasteride. Other things in related to diet, as I mentioned, you want to make sure that just for your, I always mention this all the time, stop having the bladder control your life. If you're waking up 4 times in the night, you shouldn't be. If you have to drive around with a container to pee in because you can't even pull over to the side of the road to get to a tree fast enough, there's a problem. If you're always subconscious and depressed because you're smelling like urine, because you're never making it to the toilet in time, whether you're a man, woman, or a child, modern urology can get you back on track of your life, get control of your bladder, and give you back control of your happiness. So there are no other specific supplements that you can say will stop you from getting prostate cancer. In many ways, just being of African ancestry, having either a gene, BRCA gene 1 or 2 mutation, we're predisposed to get prostate cancer. So we're not going to stop you from getting the prostate cancer, but let's make sure that you're not obese, so we're not going to get aggressive form of prostate cancer. Let's make sure we pick it up early and we can cure you very easily.
Okay, so you alluded to this earlier in the discussion, but Chris Dowell asked, is there any correlation to mothers with breast cancer and son developing prostate cancer?
Unfortunately, yes. So there is a correlation, and that's related to the BRCA gene mutation, either 1 or 2. So that's where genetic testing is very important. So you will find that in many families that men will have prostate cancer, women will have breast cancer, and a lot of people won't realize this, that men can get breast cancer as well. If you have the BRCA gene mutation, you're at risk of several cancers, from pancreatic cancer to certain forms of skin cancer. So if you have a strong family history of cancer, it's very important to get genomic testing, particularly if you're found to be positive for BRCA gene 1 or 2 mutation. Get your other relatives, whether they're male or female, tested as well, so they know the risk factors and they know what to expect in their lifetime and what we need to do to pick up prostate cancer as a urologist early, but even breast cancer.
All right, thank you. I don't see any more questions in the chat, and I don't see any more hands up. One final call. Anybody else have any further questions for Dr. Pinto?
Dr. Pinto, it would be good if you could perhaps tell us where your office is located.
Okay, so I'm a consultant at Princess Margaret Hospital, one of only 2 consultant urologists in the government system. So we are overwhelmed there, particularly with COVID. Our waiting list for clinics is very long, but you can always get a referral from any local clinic or general practitioner to the PMH clinic. In terms of my private offices, I have 2 private offices. One is my main office is at Oak Tree Medical Center, which is 5th Terrace, Mount Royal Avenue, and the number there is 322-1145. Or I'm at, if you're out west, or it's more convenient to be out west for you, I'm at Family Medicine Center on Blake Road, and the number there is 702-9301. Or the easiest thing to remember is I have a website, urologycarebahamas.com, and all my contact information is there.
Okay, so I see 2 more questions. One, can you get the BRCA gene testing done locally? And if so, where?
Yes, you can. Particularly, you can be directed to where you can get tested by the Cancer Society. And many times it's free of cost. You can privately in some of these labs get genetic testing done as well, but if in terms of free, I would contact the Cancer Society, Bahamas Cancer Society.
All right, and Galaxy Note 9, you can go ahead and ask your question.
Thank you, Dr. Pinto. Thank you. I really appreciate the information. I've learned a lot. How does alcohol or drinking wine affect the prostate, please?
Okay, so they've also done studies looking at that, and they found that drinking to excess has increased your risk of having a more aggressive form of prostate cancer. So I'm not saying not to drink. In fact, studies even looking at the benefits of red wine and its antioxidative properties. But men who drink heavily, and that's another risk factor for Bahamian men, unfortunately, who consume large quantities of alcohol, particularly on a daily basis, and the more years they do that, the greater risk they're going to have of developing a more aggressive form of prostate cancer. So everything in moderation, whether it's red meat, whether it's salt, whether it's alcohol, but if you drink to excess, you're going to have an increased risk of a more aggressive form of prostate cancer.
Okay, so we're 2 minutes past that time and I don't see any more questions. So Dr. Pinto, once again, we thank you so much for this very informative, very timely session. And again, I will repeat the take-home message: get tested, get diagnosed early. But we do appreciate it. And on behalf of the Highbury Park Church of Christ, we'd like to thank you. I would also like to send a shout out to your wife, Chanel, and Lisa Green, who helped in arranging this session. Thank you so much.
I appreciate it for the opportunity. Take care.
All right, Landy Lorota will close us out with a word of prayer. Landy? All right, Brother Kevin, would you close us with a word of prayer, please?
Okay, good evening, everybody. Let's go ahead and pray. Eternal King, the God of the heavens and the earth, we thank you for being an awesome God, a great God. You, in your wisdom, have fashioned man in a wonderful way. You have given men the prostate gland, and it functions. It's in the intent that you made it. Oh God, you're a great God. And as we look at other systems of our bodies, oh God, we look at your splendor, your might, your wisdom. Oh God, I pray that you may continue to keep Dr. Pinto, help him, oh God, in his various responsibilities. Apparently, he has his hands full along with his colleagues. I pray, God, that you may undergird him and strengthen him for the tasks that he continued to encounter. Father, I pray that you may continue to bless all those on the platform. I pray, God, that as we would have a thirst, a hunger for the medical knowledge, that we, oh God, may see the importance of having a hunger and a thirst for the spiritual knowledge that is available through your word. We just thank you. Continue to keep all of us, bless the planners, the organizers of this platform, and may you bless them, keep them. Help us all now as we separate from each other. In Christ's name I do pray. Amen.
Amen. Thank you once again, Dr. Pinto. As you leave, just say good night, and good night to you all.
Good night, everybody.
All right, good night.
Good night, all.
Good night.
Good night, everyone.
Good night,
Good night,
everyone.
Good night.
All right, good night.
Good night.
Good night.
Good night,
Good night.
everybody.
Night.
Good night.
Good night, y'all.
Good night.
Good night, all.
Good night.